lecture, we discuss the acute kidney injury, its classification, manifestation, and management. And today we will continue with the other form of the renal insufficiency, that is chronic kidney disease. As I said in the last lecture, the previous terms, acute renal failure and chronic renal failure, not used nowadays, and it is replaced by the acute kidney injury for the acute renal failure and chronic kidney disease for the chronic renal failure. What is the definitive criteria for the chronic kidney disease? It is either kidney damage for more than 3 months with or without decrease in the glomerular filtration rate, which manifested by one or more of the following features: abnormal blood or urine finding, abnormal imaging test, or abnormal kidney biopsy. This is the first criteria for the chronic kidney disease, in which there is kidney damage for more than 3 months, equal or more than 3 month duration. How I know the kidney damage occurred? By the presence of the abnormal blood or urine finding. That's mean the blood urine creatinine and the blood urine nitrogen, serum creatinine and blood urine nitrogen, and urine finding by the urinalysis, or abnormal imaging test by the IV biogram or by ultrasound, or by the abnormal kidney biopsy. If these abnormalities continue for more than 3 months, it is indicate kidney damage, which is a definitive criteria for the chronic kidney disease. Or the presence of the following in addition to the first one, yani in the presence of the kidney damage or not. The glomerular filtration rate less than 60 ml per minute per square meter for more than 3 months with or without the above signs of the kidney damage. Yani to say that the patient has the chronic kidney disease, either have damage for more than 3 months, which manifests by abnormal blood or urine test, abnormal imaging test, or abnormal kidney biopsy, or the presence of the decreased glomerular filtration rate less than 60 ml per minute per corrected square meter for more than 3 months with or without the above sign of kidney damage. This is the definitive criteria of the chronic kidney disease. The chronic kidney disease is staged depending on the degree of the renal damage and reduction in the renal function, or what we say the glomerular filtration rate. As in the refiled classification, if you remember, for the acute kidney disease. Now, for the chronic kidney disease, it is also classified into 5 stages depending on the degree of the renal damage and reduction in the renal function or glomerular filtration rate. How? In the stage 1, there is kidney damage, as we defined previously, by abnormal renal or urine test, blood or urine test, abnormal imaging technique, or abnormal finding on the biopsy. For kidney damage with normal or increased glomerular filtration rate, it is mean the glomerular filtration rate more than 90. Or kidney damage, stage 2, kidney damage with mild decrease in the glomerular filtration rate. That means the glomerular filtration rate is between 60 and 89 ml per minute. Or stage 3, moderate decrease in the glomerular filtration rate. It is mean 30 to 59. And stage 4, severe decrease in the glomerular filtration rate between 15 and 29. And lastly, kidney failure in the stage renal disease when the glomerular filtration rate less than 15 ml per minute per corrected square meter, or on dialysis, the patient on dialysis. So the stages of the chronic kidney disease depend on the degree of the renal damage and reduction in the glomerular filtration rate, as you see from this table. What are the etiology of the chronic kidney disease? It is depend on the age of the patient, differ with the different ages of the patients. In the patient below 5 years of age, the most common is congenital renal abnormality, which is the most common cause. Example, renal hypoplasia, dysplasia, or obstructive uropathy. Hyperplasia is mean underground of the kidney, and dysplasia abnormal ground of the kidney, or there is obstructive uropathy, which, as I said in the previous lecture, must be bilateral, most commonly posterior urethral valve. Second cause in the children below 5 years were congenital nephrotic syndrome, as we discussed, or Brown-Pillay syndrome, or cortical necrosis, or focal segmental glomerulonephritis or glomerulosclerosis, autosomal recessive polycystic kidney disease. We have two varieties of the polycystic kidney disease, autosomal recessive, which occur in the children below 5 years, and autosomal dominant, which is mainly in the adulthood. Renal vein thrombosis, and hemolytic uremic syndrome. These are the main causes of the chronic kidney disease in the children below 5 years of age. What about children after 5 years of age? We have in the children below 5 years, the most common cause is congenital abnormalities, while in the children after 5 years of age, we have the acquired disease, example, lupus nephritis, SLE, inherited disorder, example, Albert syndrome, and other causes might occur throughout childhood, that means below 5 years, below 5 years or after 5 years, including metabolic disorder, example, cystinosis, hyperoxaluria, or inherited disorder, example, both autosomal recessive and autosomal dominant polycystic kidney disease. As I said, polycystic kidney disease occurs in older children after 5 years and autosomal recessive below 5 years. What are the clinical manifestations of the chronic kidney disease, including according to the condition, underlying condition? The manifestation will be differ according to the underlying cause. For example, in the children with chronic kidney disease caused by chronic glomerulonephritis, like in the lupus nephritis, the patient presented with edema, hypertension, hematuria, and proteinuria. While infant and children with congenital disorders such as renal dysplasia and obstructive uropathy can present in the neonatal period with failure to thrive, polyuria, dehydration, recurrent UTI, or overt renal insufficiency. So it is according to the underlying cause. While if the cause is congenital kidney disease, can be diagnosed by the prenatal ultrasound, which allowing early diagnostic and therapeutic intervention. The most commonly obstructive uropathy, which is causing the fetal renal hydronephrosis, which can be diagnosed by the prenatal ultrasound for the fetus. So the early intervention immediately after delivery will be reduce the degree of the renal damage. About the complications of the chronic kidney disease, we have the most common and the most presenting feature, which is bring the patient to the doctor or to the physician or to the pediatrician. It is the growth failure, short stage. A lot of subtle chronic kidney disease firstly diagnosed during the workup for the short stage, which is due to the poor nutrition as a chronic condition that causes decreased appetite, renal osteodystrophy, I will discuss later, metabolic acidosis, which is causing failure to thrive, hormonal abnormality, resistance to the growth hormone, and decrease in the insulin-like growth factor 1, which is produced by kidney, which is very important for the growth of the tissue. So these are causes of the growth failure in patients with chronic kidney disease. When you ask why the patient with the chronic kidney disease have growth failure, you answer that due to the poor nutrition, renal osteodystrophy, metabolic acidosis, and other causes, as I say. Other complication, anemia, which is common complication due to decreased erythropoietin production. As you know, the erythropoietin is a product produced by the kidney, and it is very important for the bone marrow function and the production of the erythrocyte precursor. So the decreased erythropoietin will be resulting in the decreased bone marrow activity and the production of the RBCs or erythrocyte, while erythroblast and then erythrocyte. And also there is iron deficiency or folic acid or B12 deficiency as a chronic malnutrition and reduced RBC survival. These are the causes of anemia in the chronic kidney disease. Renal osteodystrophy due to the secondary hyperparathyroidism and hypertension and left ventricular hypertrophy, which is common manifestation in the chronic kidney disease. And delayed puberty, which is due to the altered gonadotropin secretion and feedback pattern. Or lastly, impaired learning and school performance because of the chronicity of the illness. During the laboratory workup, we find that there is increased blood urea nitrogen and serum creatinine due to the reduction in the renal function, or electrolyte disturbance, including hyperkalemia, which is very risky and fatal, as we discussed in the acute kidney injury. Hyponatremia, which is due to the volume overload, that means dilutional hyponatremia. Hypernatremia due to the loss of the free water, hypocalcemia, and hyperphosphatemia. These are electrolyte disturbances which might occur in the chronic kidney disorder. Acidosis and increased plasma uric acid. Hypoalbuminemia due to the heavy proteinuria. Complete blood count may show normochromic normocytic anemia, as I said, either due to the dilutional anemia or to the decrease in the erythropoietin production. Now, also we have elevated serum cholesterol and triglyceride level and decreased glomerular filtration rate measured by the endogenous creatinine clearance. I said many times renal osteodystrophy, which is the main cause of one of the causes of the short stature and the growth failure in the patient with chronic kidney disease, and responsible for a lot of the metabolic abnormalities which are occur in the patient with the chronic kidney disease, mostly the calcium and phosphate abnormality. So what we mean by the renal osteodystrophy? The renal osteodystrophy is a spectrum of the bone disorder seen in the patient with the chronic kidney disease. يعني, it is not only one disease, renal osteodystrophy. It is a spectrum. مجموعة, it is a group of the disease occur in patients with the chronic kidney disease. The most common condition seen in the children is high turnover bone disease caused by secondary hyperparathyroidism, causing skeletal pathological finding, which is called osteitis fibrosa cystic. High turnover, it is mean that there is resolution of the bone due to the hyperactivity of the bone caused by secondary hyperparathyroidism. In increased hyperparathyroid, it will be causing resolution of the bone to release of the calcium into the circulation to replace hypocalcemia. That's what mean by the high turnover. So this high turnover or hyperactivity of the bone and resolution of the bone, it will be causing cystic lesion in the bone, which is called osteitis fibrosa cystic. This is what I mean by fibrosa, osteitis fibrosa cystic. Look, this is fibrosis. Okay, due to the resolution of the bone in form of cyst. Osteitis fibrosa cystic. It is clear what I mean by the turnover bone disease. واضحة؟ إن شاء الله. Okay. How this osteitis fibrosa cystic occur, or how this bone resolution or bone turnover occur? I mean, what the pathophysiology of the renal osteodystrophy. When the glomerular filtration rate is decreased to approximately 50% of the normal because of the kidney damage, this will result in the decrease in the functional kidney mass. Functional kidney mass, that means the glomeruli and the tubule, which are important for the secretion and reabsorption of the material or electrolyte. So when the glomerular filtration rate decreases at the beginning to the 50% of the normal, there is decrease in the functional kidney mass. This decreased functional kidney mass will lead to the decrease in the renal alpha-1 hydroxylase activity, which is very important for the production of the activated vitamin D, or 125 dihydroxycholecalciferol. As you know, the renal alpha-1 hydroxylase activity, it is very important product of the kidney. Okay, so when decreased functional kidney mass, there is decrease in the production of the alpha-1 hydroxylase activity. With alpha-1 hydroxylase activity, it is very important for the activation of the vitamin D into the active form, which is 125 dihydroxycholecalciferol. That means when the vitamin D is absorbed from the intestine, it will be not active for the calcium and phosphorus metabolism because of the reduction in the alpha-1 hydroxylase activity, which is resulting in the active decrease in the active vitamin D, the 125 dihydroxycholecalciferol. This reduction in the active vitamin D will be resulting in the decrease in intestinal calcium absorption. So the calcium will be not absorbed from the intestine. This what lead to the hypocalcemia. And the hypocalcemia will be lead to the secondary hyperparathyroidism, increase the parathyroid hormone in order to activate bone marrow resolution and the release of the calcium from the bone to the circulation to replace the deficiency of the hypocalcemia. And this secondary hyperparathyroidism will be resulting in the increased bone resorption and will be resulting in the cystic lesion and decreased bone marrow, decrease in the bones strength. It is clear. Decrease in the glomerular filtration rate at the beginning to the 50% of the normal will be result in the reduction in the functional kidney mass. So there is decrease in the secretion of the renal alpha-1 1-alpha hydroxylase activity, which is very important enzyme for the production of the active vitamin D, which is 125 dihydroxycholecalciferol. And this dihydroxycholecalciferol, it is important for the absorption of the calcium from the intestine, so it will be resulting in the decreased intestinal calcium absorption, and this leads to hypocalcemia. Hypocalcemia will resulting in the increase in the parathyroid hormone activation, resulting in the secondary hyperparathyroidism, and the hyperparathyroidism will result in the increased bone resorption in order to release calcium from the bone to the circulation to compensate for the hypocalcemia, and this will result in the bone resorption. Okay. If the condition not corrected and the glomerular filtration rate declines to 20 to 25% of the normal, this will resulting in the compensatory inadequate renal phosphate excretion, because the phosphate will be excreted by the kidney, and now the most 75% of the renal mass will be damaged. So there is inadequate renal phosphate excretion as a compensatory mechanism for the hyperphosphatemia to correct the calcium. So there is hyperphosphatemia, and as you know, the hyperphosphatemia causing hypocalcemia, and hypocalcemia will be lead to the more secondary hyperparathyroidism, and the more secondary hyperparathyroidism will be an increase in the more bone resorption. This is why the renal osteodystrophy is occurring. It is clear Anyone have a
Very
question?
good.
Okay. Now, what are the clinical manifestations of the renal osteodystrophy? First of the muscle weakness, bone pain, and fracture with minor trauma because of the bone resolution. In a growing child, there is lactic changes like ricket, changes similar to the ricket due to the vitamin D deficiency, including lactic rosary, varus and valgus deformities of the long bone, and slipped capital femoral epiphysis might be seen. Like this is the lactic rosary. This is the bow leg, and this is the widening of the wrist. These are the signs of ricket, which are occur in the femoral epiphysis spontaneously slipped, separated, either stable or unstable. This is unstable form, and this is a stable form, and this is, if not corrected, will be resulting in the ischemia of the head of the femur and will be resulting in the damage for the pelvic joint. Okay, so this is a slipped capital epiphysis, and this is varus deformity of bow leg, and this knock knee of valgus deformity. Okay. What are the laboratory findings of the patient with renal osteodystrophy, including decreased serum calcium because of the hypocalcemia due to the decrease in the active form of the vitamin D, 125 dihydroxycholecalciferol, and increased serum phosphorus due to the bone resorption and decrease in the compensatory phosphate excretion due to the renal damage. Alkaline phosphatase is high due to the hyperactivity of the bone marrow, and increase in the parathyroid hormone due to the secondary hyperparathyroidism. X-ray of the bones, wrist, and knee shows subperiosteal resorption, decreased bone density, bone of the bone with widening of the metaphysis like this. This is decreased bone marrow, decrease in the bone density, widening of the distal end of the radius and ulna, and increase the distance between the distal end of the radius and ulna and metaphysis. With cupping, there is cupping of the distal end of the radius and ulna. This is the radiological finding of the wrist in the patient with lactic changes due to the decreased calcium level. Treatment of the renal osteodystrophy, including the goals of the treatment, is to prevent bone deformity and normalize the growth velocity using both dietary and pharmacological intervention. The main goal of our treatment, it is long treatment, required a lot of follow-up. So the goal of the treatment was to prevent bone deformity and normalize the growth velocity by either dietary control or by using a drug. Other goal, the target phosphorus level for the adolescent is 3.5 to 5.5 milligram per deciliter, and for children 1 to 12, between 1 and 12 years of age, is 4 to 6 milligram per deciliter. When you control for the phosphorus, it will be controlled for the calcium level. As you know, when the phosphorus is decreased, the calcium will be increased, and this will be resulting in the inhibition of the parathyroid hormone secretion, and this ultimately ends with decreased bone resorption. So the goal, maintain the normal phosphorus level in the adolescent between 3.5 to 5.5 milligram per deciliter, and for children between 1 and 12 years of age, between 4 to 6 milligram per deciliter. When you achieve this number, you will get good growth and good bone for the baby. How we reach for these goals? For these goals by the low phosphorus diet for children and adolescents and infants should be provided with low phosphorus formula such as Similac PM60/40. This is a special formula by the Similac company of the milk production, which is contain low phosphate content. Phosphate binder are used to enhance GI phosphate excretion, while vitamin D administration in form of the 0.01 to 0.05 microgram per kg per 24 hours of calcitriol, اللي هو activated vitamin D, 125 dihydroxycholecalcitriol. Now, after discussion of the renal osteodystrophy, which is the very important sequelae of the chronic kidney disease, how we treat the chronic kidney disease in general. Aims of the treatment, replacement of the decreased or absent renal function. What is decreased or absent from the renal function? We try to replace it. And slowing the progression of the renal dysfunction. حاول تطول فترة as much as possible for the good renal function. How we reach for these goals? By the monitoring of the patient, blood tests, including serum, periodic monitoring for the serum electrolyte, blood urinaturgy, creatinine, calcium, phosphorus, albumin, alkaline phosphatase, and hemoglobin level for the achievement of the good growth for the patient and for the prevention of the renal osteodystrophy. Periodic measurement of the parathyroid hormone level and bone X-ray for the early detection of the renal osteodystrophy, and periodic echocardiography to identify left ventricular hypertrophy and cardiac dysfunction and early treatment. How the treatment achieved by the fluid restriction indicated only in oliguric patients and those with left ventricular dysfunction. As I said in the previous lecture, it is 400 ml per square meter per day, which is which is equal to the insensible water loss plus the urine output, GI tract output, and blood loss if it is present. This is what I mean by the fluid restriction. We said that in lecture of the acute kidney injury. Of the administration. Treatment of the electrolyte abnormalities, including the hyperkalemia, as we discussed in the last lecture, hyponatremia by the administration of the sodium-rich solution or diet, and treatment of the metabolic acidosis by sodium bicarbonate. Treatment of anemia with erythropoietin, recombinant human erythropoietin, when hemoglobin level below 10 gram per deciliter at the dose of 50 to 150 milligram per kg per dose, subcutaneously for 1 or 3 times weekly. The dose is adjusted to maintain the hemoglobin level between 11 and 12 gram per deciliter. In patient with chronic kidney disease, because of the decreased renal production of the erythropoietin, there is pneumochronic pneumocytic anemia, as we said. So the patient required administration of the recombinant human erythropoietin for 1 or 3 times weekly subcutaneously to achieve hemoglobin level between 11 and 12 grams per deciliter. All patients receiving recombinant erythropoietin therapy should be provided with either oral or intravenous iron supplementation. As you know, the erythropoietin will be stimulate the bone marrow for the erythroblast production, and this erythroblast production requires iron supplementation, which is the major part of the hemoglobin production. So each patient receiving erythropoietin should receive, in addition to it, the either oral or intravenous iron supplementation. Treatment of the renal osteodystrophy and secondary hyperparathyroidism, as I said previously, and treatment of the hypertension by salt restriction, less than 2 grams per 24 hours, diuretics like hydrochlorothiazide if there is mild hypertension, oral hydrochlorothiazide in case of the mild hypertension, which is home therapy, or by the furosemide, which is intravenous potent diuretic therapy in severe cases. Using drug angiotensin converting enzyme inhibitors like enalapril and lisinopril, and using of the angiotensin 2 receptor blocker here, losartan. Losartan, it is now the drug of choice for the treatment of the hypertension associated with renal osteodystrophy, especially if it is associated with a proteinuria, because it will be prevent the proteinuria and this and preserve the tubular function, and it will result in the maintenance of the renal function and slowing the progression to the end-stage renal disease by unknown mechanism. So it is a very important drug for the controlling of the hypertension, for the decreasing the proteinuria, and for the maintenance of the renal function as long as possible. Treatment of the left ventricular hypertrophy by volume control, and the optimal treatment of the end-stage renal disease is by the renal transplant. The ultimate treatment is by the renal transplant. But the dialysis in two forms, maintenance, which is chronic dialysis, is effective for the child awaiting for the renal transplantation, or for whom renal transplantation is not possible. The ultimate treatment, or the optimal treatment, sorry, and the end treatment for the end-stage renal disease is renal transplant. Dialysis, chronic dialysis or maintenance dialysis, is used for the patient during the waiting for the renal transplant, or if there is, or if the transplant is not possible because of the financial causes, or because there is no compatible donor. The chronic dialysis is done by the two forms, peritoneal dialysis, which can be even done at home by the family, or by the hemodialysis, which is typically done 3 times a week at the dialysis unit in the hospital. What are the indications of the chronic dialysis or maintenance dialysis? Are poor growth, stage 5 chronic kidney disease, or what's called end-stage renal disease. These are 2 indications for the chronic kidney disease. About the prognosis of chronic kidney disease, stage 1 and 2 may do well, but need to be monitored for progressive loss of the kidney function. And children with the stage 3 and 4 have a high possibility of a progression to the end-stage renal disease, which is ultimately required renal transplant. Children with kidney transplant generally do well, but immunosuppressive medication associated with a variety of side effects, including infection, nephrotoxicity, cardiovascular complication, and increased risk of the certain malignancies. So unfortunately, most transplanted kidney die over time, but can last for several years. In Iraq, the most extended period for renal transplant, it is not more than 5 years, unfortunately. This is because of a lot of conditions, including infection, and other complications. Children on maintenance dialysis have the highest morbidity and mortality, especially with longer time spent on dialysis. As you know, the dialysis might be resulting in thrombosis, might resulting in the infection, might resulting in the electrolyte disturbance more in wrong technique. So the children which on the maintenance dialysis have a highest mortality and morbidity. Thank you for your nice attention. That's all about the no.